I'll approve this. Yeah.
You unmute, please unmute yourself.
Kajari?
Yeah, sorry ma'am. So what we are seeing is these three sets of images. The central one is the T2, which we look at. So first we are seeing that this is obviously a right-sided lesion, and the location of the lesion is in the right temporal lobe. Now temporal lobe harbors a very distinct type of tumors, and these present with epilepsies. And therefore temporal lobe epilepsy is a very common presentation of these tumors. Now in contradistinction to the previous tumors where we are seeing that these tumors were having ill-defined margin, if we see at this tumor is having a very well-defined margin. There is no significant perilesional edema, and it has two components. So if we see on T2, this has one component which is a little bit intermediate or a little bit solid one, and there is a cystic component which is more posteriorly located. So what we are seeing again in the FLAIR image, this cystic component is showing completely inversion. So it's following the CSF signal, or it is completely inverting, again signifying that this is a cystic component, and this is the solid component. When we go to the post-contrast study, we are seeing that the solid component is showing intense post-contrast enhancement. So basically, there is a terminology in radiology where we say that it is a tumor which has a cyst with a mural nodule. And this mural nodule is a little bit eccentrically located. It is more anteriorly located, right? So we are seeing what is basically a circumscribed lesion which has a cyst with a mural nodule morphology and no significant perilesional edema, which is present in the right temporal lobe. And therefore, my differentials radiologically will be a circumscribed astrocytoma, whether it's a pilocytic astrocytoma or circumscribed, or it could be a pleomorphic xanthoastrocytoma or a glioneuronal tumor like a ganglioma. So these will be my radiological differentials.
Excellent. So cyst with the mural nodule, please remember temporal cortex, and she has very nicely described with 3 differential diagnoses. So
just one point, Vani.
Yes.
You know, the T1 contrast is very well seen in the medial near the sylvian fissure, but if you look at the T2 and the flares, there seems to be at the posterior medial aspect of the enhancing nodule some other abnormality. Is that part of the...
Yes, so basically, sir, this part, there is a second component. So if we look at the FLAIR image, we are seeing this dumbbell kind of configuration, whereas only one part of the tumor is enhancing brilliantly. So the entire solid component is not enhancing, and this is a little bit more intermediate on T2. So there may be a little bit of heterogeneity within the tumor also. So then in that case, again, I would again have to look at a gradient image to see whether there is any calcification present within this tumor. And then I would think more in terms of a PXA and a glioneuron and a ganglioglioma rather than a pilocytic astrocytoma.
Exactly, crossed my mind too. You could also do the flare, the diffusion weighted imaging to see the whether there's an restriction. It looks to be a pleomorphic xanthoastrocytoma more than a pilocytic.
We have some very brilliant clinicians over here. Very difficult for me to... Okay, let me share this again. So, here we go. So, Nagma, do you want to quickly describe or do you want me to describe?
Nagma,
Try.
Yeah.
Try. So you can see a tumor. See, this has come right up to the surface. Actually, this is the leptomeninges. A tumor has come up. It is very superficially placed. Whatever was removed was superficially placed. And let me tell you that it was quite firm in consistency. And here, what can you make out? Sorry? Okay, don't bother about it. I will describe because we are running short of time. You remember Dr. Kajari said that she felt it was more a circumscribed tumor than a diffuse tumor. Here what you can see is a nice pushing margin. This is the tumor and this is the brain parenchyma. There is some calcification. There is a pushing margin over here. See, in the brain, no brain tumor is encapsulated, okay, within the parenchyma. When we say a circumscribed tumor, what we mean is histologically it will have some sort of a pushing margin. And the tumor was very firm because you can see that this is a reticulin stain. Again, a very useful stain. And the tumor shows dense reticulin fibers in the background. And you can see now so beautifully it is circumscribed, and it is really having a good pushing margin from the rest of the parenchyma where only the blood vessels are reticulin positive. But here the tumor has intrinsic positivity with reticulin. Now you describe. Now this is easy. You can describe.
There are large multinucleated xanthomatous cells.
Very good. Very good. What is this?
There is intracellular accumulations of lipids
In some of these cells, yes, it appears lipid. It is just sort of, it is pale and xanthomatous. Yes, I agree. What is this one? Just give me these features. That's more than enough. What is this? Very good, very good. Who said that? Ivani?
Yes, ma'am.
Yes, what is this? Perivascular lymphocytic infiltrates, tumor infiltrating lymphocytes, pleomorphic cells, large cells, some of them have binucleation. And then what is this? This you must tell me. Nagma. Eosinophilic granular body. This is a very typical eosinophilic granular body. So this is eosinophilic granular body. Now you can see the spindle-shaped astrocytes, numerous eosinophilic granular bodies, and then these what you called as lipidized cells. You see that? They're all pale and lipidized, these cells, and prominent perivascular tumor-infiltrating lymphocytes. Is there mitosis?
Yes.
No.
Yes, ma'am.
No mitosis. They're only nuclear. It's pleomorphic, very pleomorphic, but there is no mitotic activity. Okay. And at certain places, you can see this epithelioid-like cells. What we saw in epithelioid GBM, you can see some accumulation of these epithelioid cells, but they don't have any mitotic activity. So we have done diagnostic IHCs. GFAP is positive or negative?
It's positive.
Positive. It's variably positive. Most of the tumor cells and their processes are positive. These pale lipidized cells, they don't take up GFAP, so we call it positive. We did synaptophysin because some of them had the ganglioid-like appearance. So we were, like Dr. Kajari said, gangliogloma is a differential diagnosis, but synaptophysin is negative. P53 is negative, so we have ruled out some giant cell glioblast. All those things we have ruled out. I have shown an area which is slightly higher, but the MIP labeling was very low in this case. It was less than 5%. Then I have done this particular stain. Any one of you can tell me what the stain. What did you diagnose with all this?
Black PV 600E. Yes, ma'am, Siddhi.
It's very good, Siddhi. Full marks for you. So this is the V600E. So this has come strongly positive. So now, Siddhi, you tell me what is your diagnosis, and you have a differential diagnosis.
This is pleomorphic xanthocytoma, and the differential is glioblastoma, epithelioid glioblastoma, and high-grade astrocytoma with pyloid features.
Wow, she's gone through WHO CNS very nicely. So yes, the diagnosis is pleomorphic xanthoastrocytoma. I've already given a CNS WHO grade. Why did I give a CNS WHO grade? Because the essential diagnostic criteria does not require molecular markers for this particular tumor. So pleomorphic xanthoastrocytoma, as Dr. Rakesh and Dr. Kajri had already made the diagnosis, and they're absolutely correct. It's a circumscribed astrocytic glioma. We have 6 tumor types in this group of circumscribed astrocytic glioma. Most of them occur in the pediatric age group, but some of them occur in the young adults also. And one of them is pleomorphic xanthoastrocytoma. What is pleomorphic xanthoastrocytoma? As the name indicates, it's a pleomorphic tumor which has xanthomatous cells, as you saw. It is astrocytic because we saw GFAP positivity. Usually occurs in children or the young adults. Most often temporal cortex superficially placed tumor assist with mural nodule is the characteristic feature. Patients present with long-standing seizures. there are two grades, CNS WHO grade 2 and 3. The grade 3 tumor was earlier called as anaplastic PXA, but we don't call that now. We just say CNS WHO grade 3. Now, these tumors characteristically harbor the BRAF V600E mutation, but that is seen in only 70 to 80% in grade 2 and about 50 to 60% in grade 3 tumors. And they also simultaneously have the CDK and 2AB homozygous deletion, which we don't have to demonstrate. Because the essential diagnostic criteria for PXA is only histological. It's an astrocytoma with pleomorphic tumor cells, including large multinucleated cells, spindle-shaped cells, xanthomatous cells, and eosinophilic gland bodies. And all others, including reticulin, BRAF, CDKN2AB, DNA methylation profile, everything is a desirable criteria. And a grade 3 tumor has high mitosis. Usually it will have more than 5 mitosis in 10 hypophytes with or without necrosis. So that will be a grade 3 tumor. And as you rightly said, if you look at the differential diagnosis, the first differential diagnosis is ganglioglioma, which is a grade 1 tumor. Most features of PXA will be like ganglioglioma only. But what we see in ganglioglioma, that is, we'll see tumor infiltrating lymphocytes, we see pleomorphic cells, we can see eosinophilic granular bodies. But in ganglioglioma, you have this clustering of neoplastic ganglion cells, which is not there in PXA. And that clustering of neoplastic ganglion cells can be highlighted by using stains such as chromogranin or synaptophysin. So you may have an occasional cell that is synaptophysin positive in PXA, but this clustering is very, very typical of gangliogliomas. CD34 is positive in both the tumors. But in PXA, it's usually the tumor cells that are positive, and in ganglioglioma, it is the adjacent ramified neuritic processes that are positive. So these are some soft histological IHC signs that you have to take into consideration. Now you may ask me the question, why should I differentiate ganglioglioma from PXA? PXA is a grade 2 or a grade 3 tumor, and ganglioglioma is very benign. It's a grade 1 tumor. Epithelioid GBM is a close differential diagnosis for grade 3 tumors, particularly when they have those epithelioid cells. They are known as epithelioid PXAs. You can have those epithelioid cells even in PXA. It becomes very difficult to differentiate because all markers will be the same. Even BRAF V600E positivity is seen in both. The only few points that we take into consideration is that in epithelioid GBM, there will be areas of necrosis, microvascular proliferation, which may or may not be there in grade 3 PXA. And PXAs, grade 3 will have lower grade areas and eosinophilic granular bodies. You must identify that. It's a regressive change. You have to identify that to call it as a PXA, which will not be there in epithelioid GBM. It's very difficult sometimes to differentiate the two, and many pathologists have made this mistake. If you look at the prognosis of PXA, although it is very pleomorphic, it behaves in a less malignant manner, but frequently it recurs. It can even progress to grade 3 tumors, and therefore complete resection is always beneficial. And adjuvant therapy is indicated, including targeted therapy with BRAF inhibitors, particularly in partially resected and in grade 3 cases. Okay, that's about pleomorphic xanthoastrocytoma, which is a circumscribed astrocytic glioma. Did you understand that? Any questions? Rakesh, any comments?
I mean, just a couple of comments. Beautifully shown case. PXA, I just want to highlight over a period of time, we used to lump them in these low-grade tumors, the PXAs, DNETs, pilostics, maybe 20-25 years ago when we were students. But obviously we realized PXA is not a simple tumor, so you have to keep a very close watch even in grade 2 tumors. And grade 3 tumors obviously are much more aggressive. They are not as bad as GBM, of course, but the long-term survival is only 35 to 40%. Grade 2, of course, have 80 to 90% survival if you do it well. One of the points to differentiate grade 3 PXA and epithelioid GBM on MRI is also if they have bleeding. Many a times epithelioid GBMs, they present with bleed, and it's the cortical location. And many a times in our clinic, we look at the MR and we think whether it could be an epithelioid GBM. And they need not have the cystic and only the nodule. They can be solid also epithelioid GBM as compared to PXAs. And finally, epithelioid GBM, they have two variants. One is very early aggressive behavior with extensive leptomeningeal metastasis. But some of the epithelioid GBMs, in fact, we have analyzed the data and we are submitting for manuscript for the publication, that some of them do very, very well. I have long-term epithelioid GBMs for 5-7 years, and we have gone back whether they could be PXA, whether they had V600E mutation, and you have to see the reticulin is a very important stain, what you rightly said. I always ask for reticulin because that can differentiate a lot of tumors. And if you have a bleed on them, they tend to be epithelioid GBM, and we use radiation, sometimes targeted therapies for many patients, what is called MEK inhibitors, a dual combination of MEK inhibitor as well as the BRAF inhibitor, and they do very well. Finally, last point, all of them may not show V600E mutation. There can be other variants of also V600. Occasionally, if there's a strong clinical suspicion, we recently had one patient, strong suspicion, twice surgery done from Calcutta. Eventually, it was V600R when we did run NGS. So you have to have clinical and pathological threshold to subject to the subsequent therapy. So a couple of, I thought these comments would help.
Very, very useful. It's really a few points that take home message. I think is really good, particularly on MRI, how to differentiate, because many pathologists have this problem between epithelioid GBM, and I keep getting referrals that please tell us whether this is a grade 3 PXA or whether this is epithelioid GBM. So there is a lot of problem with that. Thank you so much for that. I'll just show you one last case. We'll go very fast on this case.
Vani, just to interrupt you, there are still 198 delegates, and I would like to tell them after this last case of Vani, Kajri will do 5 minutes quick 6-7 scans. So please don't go away and listen to Kajri, Dr. Kajri for this.
Sure.
I know that this guy, Jalali must be hungry. Jalali dinner can wait.
No, the presentation is very delicious. We are enjoying. It's a feast.
So I'll ask maybe Akshpita, can you come back to this case? There's a 21-year-old lady who came to our epilepsy clinic. Actually, she complained of she had complex partial seizures for about 10 years. She was on anti-epileptics. She did not have any relief from her seizures, but she did not have any raised intracranial pressure. There were no neurological deficits, and she was diagnosed as drug-resistant epilepsy. So she has come to our clinic, to our epilepsy clinic, for evaluation. And these are her scans. Kajri, if you can just quickly describe this, I'll approve your annotation. Yeah.
So what we are seeing is these 4 sets of images. Again, we look at the T2. What we are seeing is basically this lesion. If we see and compare it with the other lesions, again, this is a very well circumscribed lesion. It is located in the cortex, and basically it is located in the temporal lobe. So it's a temporal lobe cortex lesion, and there is no perilesional edema. So it's a very homogeneous lesion. It's a very bright lesion on T2-weighted image. And one very important feature is, if you can see this, there's a scalloping of the overlying cortical bone, which signifies that it's a long-standing lesion. So that's a benign, long-standing lesion which is present in the temporal lobe cortex. So if we look at the T1, it's hypointense on T1. Obviously, we have to look at the contrast, and I'm not expecting much of a contrast enhancement in this case. There is no diffusion restriction. There is no blooming or no calcification in this. So a cortex-based this finger-like lesion, which is having scalloping of the overlying bone, I would put my diagnosis as a TNET in this particular case, the right temporal lobe.
Rakesh?
Yes, I agree with it.
Comments?
No, it's fine. I think it is DDET because of the scalloping. And mind you, she presented at the age of 11. She's 21 now, and she has a history. And if you have to stretch your imagination, sometimes hamartomas you have to always think of occasionally, although there have to be other sequela. And oligos sometimes pathologically can be confused with the DNET, and the age is important. One final comment, Kajri will bear with me. As a clinician, sometimes they may ask the pathologist, no, but I saw the edema. Sometimes these patients present with a seizure and immediately an MRI is done, and you have a typical periictal edema.
Yes.
but it is a long-standing process. They may not carry the old scans with them, or they may not tell you the history because they are in a post-ictal confusional state. And sometimes it looks like a high grade actually because of the so much edema, which is post-ictal. And they will say, no, it is high grade, you tell me. And the pathologist, of course, say it is D-net or a low grade. It's a small, subtle clinical point.
Yes, and I would also like to add that if the patient is presenting just after an ictus and there is edema, we can also expect in a diffusion weighted imaging to see those post-ictal changes, which we'll see as diffusion restriction along that particular cortex. So that could also be an indicating finding.
Okay, thank you. Thank you so much. And again, it's quite a simple case but a very nice case. You can have a look at the histology, which is very interesting. So this patient came as a part of our, epilepsy clinic program, and the lesion was resected en bloc. Usually we don't get samples like this. It will be very fragmented for the pathologist, but here you can beautifully see it's an en bloc resection of the tissue. And what you can see here, this is the gray matter, and what you can see here is the white matter. And in the gray matter, I hope you can see all these multiple pale nodules, cortical nodules. They're in the gray matter. White matter is unaffected. It is spared. See, most of the diffuse gliomas, they arise in the white matter and then they spread to the gray matter. But here you can see that it is cortically based. It is in the gray matter and the white matter is spared. And this is one large pale nodule in the cortex. And this is the adjacent gray matter. This was the portion of the white matter. And this is that circumscribed nodule, pale nodule in the gray matter. And higher magnification shows you three important things. You can see these spaces. Can anybody, Akshpita, can you tell me what these spaces are? Microcystic spaces. And what are they lined by? Oligodendrocyte-like cells. And what are these?
These are
Floating neurons. So this is the higher magnification. You can see three important features. Please observe them in the gray matter. Multiple pale nodules. The nodules are composed of these microcystic spaces lined by small round cells. They're oligodendrocyte-like, but they're not true oligodendrocytic cells. And there are these floating neurons. There is no connection at all. Look at the neurons. They seem to be floating in this, in the microcystic space. And this is the typical glioneuronal element. And these microcystic spaces can have a myxoid-like material. You saw this? It has this myxoid-like material within the microcystic space. We can sometimes, if it is not very clear, you can highlight that by a special stain. I've used one special stain here. Can somebody tell me what special stain I've used for this myxoid matrix? Which one?
Alcian.
Very good, 100 marks. Alcian blue. I've used Alcian blue, and with Alcian blue, you can see how beautifully these microcystic spaces with the myxoid material is highlighted. Can you name one more CNS tumor where the stain is very useful? See, Dr. Rakesh said reticulin is very useful. He likes reticulin stain very much for so many tumors. Another stain I like a lot is Alcian blue. It's very good for these tumors. This is a D-net. There is no difficulty in diagnosis. But you can also use it for another tumor. Can you tell me one example where you can use Alcian blue?
Myxopapillary ependymoma.
Who said that?
Yes, ma'am.
Siddhi, you're too good. Very good. You use it for myxopapillary ependymoma because not all myxopapillary ependymomas on histology will show that myxoid core in the papillae. You cannot identify in all tumors. When you can identify histologically, it's good. But if you can't identify, please use Alcian blue. Alcian blue helps a lot. I keep telling my residents, please use Alcian blue for these tumors. Okay? So Alcian blue is positive. So how does this GFAP stain this? Are the tumor cells positive or negative? What is staining? Negative.
Our astrocytic cells are positive.
These are the stellate astrocytes. They're the reactive cells. You see these reactive astrocytes? Reactive astrocytes have many processes like this, like a spider. Looks like a spider. So they're known as stellate or reactive astrocytes. Tumor cells are negative. And the processes that were lining these microcystic spaces, these are the floating neurons. The processes are all stained by this neurofilament protein and synaptophysin. That's why it is glioneuronal. There is some glial element, there is some neuronal element. Nu-N is a neuronal nuclear stain. It is meant for entrapped nuclei, dysmorphic nuclei, but not the neoplastic ganglion cells. You don't use it for ganglioglioma. Here you can see that some of the floating neurons are Nu-N positive, so you know that they are floating neurons. And only one cell is labeled by MIB. It is very, very benign. So what is our diagnosis? Differential diagnosis. Any molecular test to make the diagnosis? We don't need any of that. This is a dysembryoplastic neuroepithelial tumor called as DNET. CNS, I've given the full diagnosis, CNS WHO grade 1. Now what is DNETs? DNETs are tumors that occur in children or young adults presenting with refractory epilepsy. They have the pathognomonic glioneuronal element which comprises the microcystic spaces, oligodendrocyte-like cells. You can use OLIG too. They will be positive in those OLCs. I didn't show you one stain, but they'll be positive. And floating neurons. Now the characteristic alteration is the FGFR1 alteration, different types of alterations of FGFR1 gene seen in 40 to 80%, and about 50% also show BRAF-V6 and a D mutation in DNETs. But you don't have to have any of those molecular alterations to make a diagnosis. Essential criteria is only histological cortical glioneuronal tumor with the presence of specific glioneuronal element. Only if it is unresolved you have to use the genetic alterations, but otherwise you don't need that. There are three histologically recognized patterns in DNET. One is the simple DNET with this unique glioneuronal element that all of us saw. One is called as complex DNET. Now these DNETs will have a glioneuronal element. Along with that there will be some glial nodules that can resemble pilocytic astrocytoma, oligodendroglioma. There can be calcification. It becomes difficult to diagnose. And then you may require molecular markers. Diffuse or non-specific forms that can lack a glioneuronal element. It can have a lot of diffuse, non-specific histology. They've been termed, some people called it diffuse oligo, some people call it DNET-like tumor, some people called it as glioneuronal tumor, NOS. So sometimes when it has this diffuse non-specific histology, it becomes difficult for a pathologist to diagnose. We may have to use the molecular alterations. Close differential diagnosis, as Dr. Rakesh already mentioned, is oligodendroglioma. Here, of course, the tumor the patient started her symptoms when she was only 11 years old. So oligos don't occur in the children. But sometimes it can be seen in older, in young adults also. So oligodendroglioma is one differential diagnosis, but here you will have to show IDH mutation 1p19q co-deletion. There is a new glioneuronal tumor type described in WHO CNS5 called myxoid glioneuronal tumor, which is like a DNET-like tumor but occurs in the deeper structures like in septum pellucidum, corpus callosum, periventricular white matter, and that will have GFAP and SOX10 positivity. And of course, the other tumors like the plenty, MVNT, don't bother about that. They are the differential diagnosis. So DNETs are all very benign tumor. Here the surgery is basically performed for relief from seizures. It is not for oncological purposes because malignant transformation actually does not occur in these tumors. There are anecdotal reports where there have been malignant transformation of DNETs. So finally, this is how the glioneuronal tumors are classified in WHO CNS5. I've compared the 2016 with the 2021 classification. What is in red fonts are the histological features, green fonts are the new tumor types, and what has been striked through are what is deleted in WHO CNS5. So the glioneuronal tumors that are composed predominantly of ganglion cells are ganglioglioma, gangliocytoma. There is no anaplastic ganglioglioma anymore. Desmoplastic infantile ganglioglioma or astrocytoma. Multinodular and vacuolating neuronal tumor, which is a newly described tumor. And dysplastic cerebellar gangliocytoma known as Lermite-Duclos disease. All of them are characterized mainly by ganglion cells. But there are tumors that are characterized by neurocytic cells. like central neurocytoma, extraventricular neurocytoma, cerebellar liponeurocytoma, papillary and rosette forming glioneuronal tumor, and this diffuse leptomeningeal glioneuronal tumor with glioneuronal tumor or DLGNT. These are all composed of neurocytes. And there are tumors composed of oligodendrocyte-like cells predominantly, like our tumor, that is DNET, myxoid glioneuronal tumor, and this new tumor type known as DG-ONC, which you don't have to bother. And paraganglioma has been removed from this group of tumors. But what is good for us pathologists is that there are 14 tumor types in this group of glioneuronal tumors. 11 of them can be diagnosed only with histology and with required IHCs, diagnostic IHC markers. You don't require any molecular you don't need to demonstrate any molecular alterations. Only for two, that is papillary glioneuronal tumor and DLGNT, you have to show the molecular alteration. And there is one newly described tumor type which is provisional, that is known as DG-ONC, which is defined by methylation profiling, so don't bother about that. But do remember that 11 of them can be diagnosed only by histology. Okay, and you use the right IHC markers or the special states. So you're absolutely correct. The diagnosis here is this embryoplastic neuroepithelial tumor. Rakesh, comments, Rakesh?
It was pretty well covered. Surgery is a treatment of choice because not only it cures but epilepsy, which can be very, very difficult in these children and young adults. And sometimes patients and families are reluctant when they tell them it's a very benign thing. So oncologically, they will not progress, but epilepsy impairs their quality of life and their education. So you have to motivate them to undergo surgery, but otherwise they are eminently curable. I wanted your one comment on this relationship with hematoma, because some people say DNET is not really a tumor, it is basically hematoma, and sometimes it can be confused actually with hematoma.
What happened was when it was first described, I don't know if you remember, it was first described in the year 1993 by Catherine Thomas-Dupont. Unfortunately, we've lost her, but she is from St. Anne Mayo Clinic in Paris, and she was the one who first described DNET. And till such a time, these tumors were called as hematomas only. And she first said that no, this is not a hematoma, it is a tumor, and it is a very low-grade tumor, and it is a glioneuronal tumor, and subsequently it was included in the classification. So tumor-like was what was thought of. But as I told you that if the tumor has this complex DNET kind of a pattern, it may have a small glioneuronal component, but the rest of it can be just like a hematoma. You can say glioneuronal nodules, hematomatous nodules inside that. And the other thing is that DNETs can coexist with focal cortical dysplasia. So FCD type 3A, 3B will have these tumors associated with the focal cortical dysplasia. And that is also a hematomatous. So it comes under FCD classification also. So that is the importance, and you're right. It was thought of for a long time as hematoma, and even now in FCD it can coexist with focal cortical dysplasia.
I mean, the point of complex DNET also is a little bit of a debatable point. Although it is recognized as an entity, to actually diagnose this is not easy. You have to demonstrate a very clear-cut neoplastic glial pathology, which is actually extremely rare. Some people have tried to publish also complex DNET. It's not easy to get published a complex DNET case because you have to convince the reviewer whether there is any complexity involved in it. And if there is, those are the cases sometimes who may recur and progress later on. Okay. In a small, tiny percentage of these cases, because they are driven by, obviously, they have a different kind of a profile and glial. And other tumors, we don't have time. They're all interesting cases. For example, the RGNT, the Lerman tumor.
Yeah, I will take one session on glioneuronal tumors separately, but you're absolutely right. Thank you so much for that. I think he has really given us some pearls of wisdom, I should say. And I think I'll stop at this and just want to tell the students that very recently we have published this textbook. This is the second edition of Essentials in Diagnostic Surgical Neuropathology, where a lot of tumors and even non-neoplastic lesions are covered, and it is they're all, it is very concise, and everything is described point wise and very easy to understand. So for those who are interested and who want to quickly go through the tumors, and you don't have enough time for W2C and S5, you can go through this book, which has all the information in a point wise and a concise manner. So with that, I think I'm going to stop now, and thank you all for your very, very patient hearing.
I think Kajri, thank you, Vani, very much. I think Kajri will take 5 minutes. In the meantime, if there are a couple of questions at the end of Kajri's presentation, we can take them. Kajri, over to you.
Yes, sir. Thank you so much, ma'am. I hate to go after you because that was such a brilliant session. And I don't know whether I'll be able to do any justice to this after your brilliant session, but still I'll try, ma'am. So, so basically the idea of...
Can you make it full screen?
Yeah. So the idea of this presentation is that I just want the MD pathology residents also to have a little bit of idea of the radiology, because obviously when a patient presents with a symptom of a clinical features which is suspicious of a brain lesion or a tumor, then we always do an MRI brain. So these are the basic sequences which we acquire in all the tumors of brain, and other than that there are some specialized sequences which we acquire as and when needed. So just to identify, so first this is an axial plane, this is a sagittal plane, and there is a coronal plane. So there are multiple planes in which these images are acquired. And how do we identify these sequences? So first and the basic sequence is a T2-weighted sequence, T2-weighted image, in which, how do we identify that? This one, this is the gray matter, it appears, the gray matter appears a little bit brighter and the white matter appears a bit darker. So the gray is bright and the gray is white and the white is gray. So basically the opposite of what we see in T1. So T1 is the basic sequence in which the gray is gray and the white is white. Opposite of that is seen in T2. And in T2 we see these ventricles. These have the CSF spaces, so these appear bright. So we see a T2, a T1. We also take something which is called as flare, which is just similar to T2, but the CSF is suppressed, so this appears black. This sequence, that's a gradient or an SWI sequence, is important because it shows calcifications and microbleeds which help us diagnose various types of, so in terms of gliomas, if you're looking for an oligodendroglioma, or if we're looking at a GBM where we need to see bleed, and an oligodendroglioma where we need to see a calcification, then that can help us. A diffusion image shows, in terms of tumor specifically talking, it can actually show us the cellularity of the tumor. So what we mean by diffusion restriction is that the cellularity of the tumor is high. So in that case, this will appear bright in this DWI image, and it should correspondingly appear darker in a ADC image. So these two images go hand in hand. And finally is a post-contrast image, which is on a T1 weighted image, we give a contrast, which is a gadolinium-based contrast agent, and where we can see that whether that tumor is enhancing or not, and that gives a basic idea about the grade of the tumor. So first thing is how to differentiate between a circumscribed and diffuse lesion. So here we can see this is a lesion which is present in the right frontal lobe. The margins of the lesion are not well delineated. So this is a diffuse lesion. Whereas in this case, the margin of the lesion is so nicely appreciated. It's very well circumscribed. So this is how you differentiate between a diffuse and a circumscribed tumor. So whenever we're looking at an image, first we look at what is the location of the tumors, whether it's a deep or it's a superficial tumor, it's located in the cortex or the white matter or a periventricular region, and what is the character of the tumor. So whether it is a circumscribed tumor or it's a diffuse tumor. So in general, the basic character of all the tumors are they're a little bit hyper intense or they're bright on T2 weighted image. So the next thing is, the very specific imaging feature which we talked about in our first case, that is an IDH mutant 1p19q non-co-deleted tumor which shows a T2 flare mismatch. So this is a hyperintense on T2 and it shows inversion in flare. So that this is a clear idea that this is a 100% specific and almost 40% sensitive for an IDH mutant 1p19q co-deleted tumor. So if you see this in your MRI, you can be sure that your pathological diagnosis is going to be this. So in contradistinction to this one, where we don't see that T2 flare mismatch, this is not this kind of a tumor. So how do we differentiate differentiate a lower grade glioma from a higher grade glioma or an astrocytoma. So in the lower grade tumors are generally homogeneous like this. They are very homogeneous. They are generally hyper intense, so they are bright on T2. They don't show any diffusion restriction, though they are not bright on DWI and they are not dark on ADC. There is no enhancement or there is intense post-contrast enhancement or homogeneous enhancement as we see in pilocytic astrocytomas. There are no signs of neoangiogenesis or no microbleeds as we see in the SWI or the gradient weighted images, and there are no necrosis, so therefore there is no enhancement. It's a very homogeneous tumor. And looking at this perfusion imaging also helps us. So basically perfusion tells us that what is the amount of blood flow to that particular part of the tumor. So lower grade tumors, they generally have lower blood flow. There are exceptions to that, but that can tell us that it's a lower grade tumor. So now we come to the features of the higher grade tumor. So as the tumor grows in its grading, so when it is basically a grade 2 tumor, these are the features which I showed in the previous slide. As it becomes a grade 3 and grade 4, these are the basic changes that we see. So it becomes more darker on T2, that is, it shows T2 hypointensity. It shows diffusion restriction, that is bright on DWI and dark on ADC, and it becomes more heterogeneous with features of neoangiogenesis, which I show. So look at this particular tumor. There we see this is a tumor which is hyperintense on T2, which is present in the left insular cortex, and it is involving the gangliocapsular region also on the left side. So this is an MRI at one point of time, and 3 months after this particular MRI, what we are seeing is that this region, this tumor, which was predominantly homogeneous in the first MRI, has become a little bit more darker. So what we have in mind is as the T2 hypointensity or as the darkening component increases, it becomes a more higher grade tumor. So if you look at the diffusion weighted imaging, we can see that this is becoming bright on diffusion and it is showing darker areas on ADC. So that means this is again becoming more cellular, and it is showing some areas of post-contrast patchy enhancement. So enhancement, patchy post-contrast enhancement, diffusion restriction, and areas of T2 hypointensity, they signify that basically the tumor is growing in its cellularity. So this is basically a grade 3 astrocytoma. And finally, the most heterogeneous of them is this particular tumor. So we see a butterfly kind of lesion which is present in the corpus callosum genu, which is again very, very heterogeneous on T2 and flare, and there is significant these vasogenic edema or finger-like projections around it. There is significant diffusion restriction, so bright on diffusion and dark on ADC, and these foci of blooming on SWI, they signify the neoangiogenesis and bleeds which are present within the tumor, which again signify a higher grade. And if you look at the enhancement in this particular tumor and compare it with the previous ones, this is intense enhancement, but there are areas of necrosis, so it's a heterogeneous enhancement. It's not homogeneous, or in contradistinction to previous where there was no enhancement, there is intense enhancement, but it is necrosis with central area and central non-enhancing areas. Again, if we perform a perfusion study, which is again an advanced sequence, we can see that these red areas, they signifying that this is a highly perfused tumor, or the blood flow to the tumor is quite high. So this is how radiologically also we can say that whether this tumor, where the tumor is located, and what is the nature of the tumor in the sense whether it's a circumscribed or a diffuse. It's an IDH mutant 1p92 non-codulated tumor. And then what is the grade of the tumor depending upon how it looks on T2, what is the diffusion signal, are there any bleeds present in the tumor or not, what is the type of enhancement, and what is the diffusion signal. So I hope that this little bit of explanation helps our residents.
Thank you, Kajali. That was very good.
Thank you so much.
Kajali and Dr. Vani and Rakesh. Do you have any final comment, Rakesh? You would like to say something to students? There are still 123 students here.
Well, it was a fascinating session. As much as any other student, even I learned a lot. It's always a great pleasure to listen to Vani, and Kajali, I'm very impressed with your passion. I think we should collaborate a little bit more.
Yes, sir. Absolutely. It's a pleasure to meet both of you, all of you, and it was a wonderful learning session for me. Even this is just brilliant, mind-blowing. I have no other words. Thank you so much for the invitation, and thank you, ma'am, for this wonderful presentation. It's a pleasure to be a part of this session and this panel. Thank you so much.
Comments, if I may make, for the benefit of all the budding pathologists, especially neuro. Neuro is looks very complex, very rapidly changing. We are just recovering from one classification and the other classification comes, and the NGS and molecular is just taking the breath away from you. But it is a most marvelous and fascinating branch, and I hope some of you take it up in a little bit more serious manner. But as you know, in all oncology or all medicine, pathology, you have to make very good friends with radiologists, urologist, and also the clinicians. You will not believe, a child comes in our clinic, my resident has to tell what is the diagnosis. Is it looking like an ependymoma, or is it looking like a group 3 medulla or a windpipe type of medulla? So we try to, challenge ourselves, because you can tell sometimes. Even the ependymoma versus medulla, ependymoma versus pilostic. Pilostic low grade will be very good in children. The one who is in a very bad shape is definitely a high grade. So these are some of the points which you may help when you are struggling a bit. And you don't, unlike other like breast cancer or a sarcoma where you have tons of tissue, the margins, there is no margin, you get very small tissue. So you are totally dependent on the clinical profile as well as on the pathology, as well as on the radiology. And joint meetings, every single joint meeting and tumor board, wherever you have a chance, these days now it is online, you should not miss. What you will learn from them in the clinical follow-up is just incredible wealth of knowledge, which hopefully will help you to correct diagnosis. And as I keep on telling Sushma, our pathologists, sometimes patients come to us, cancer patients, sir, hum प्रार्थना करते हैं कि क्या होगा, shall we pray? I said, pray for the pathology. Because pathologists are gods. They will tell you whether it is benign, malignant, grade 1, grade 2, grade 4, NGS. I cannot do anything as clinician if the pathologist says glioblastoma finished. But if she says it's a pilostic or a grade 2, the prognosis change. So pathologists actually have much, much more responsibility, especially in brain tumors, than actually any clinician. So with that, I thank you very much, and I wish you the very, very best for the betterment of the patients. Thanks so much.
Dr. Vani, you have any final comments for students or for anyone?
I think Rakesh has said it all, and I have heard Rakesh for years and years now and learned so much from him. And he's very right. We require clinicians, we require radiologists, and multidisciplinary meetings are very important. I tried to make it as simple as possible so that the students could understand, and because I know that once the pathologists, particularly the young pathologists, hear the word molecular, they run away from it, and they say we don't know how to diagnose their molecular. But it's not all that difficult. You have now everything is available. All surrogate IHC markers are all available, and we have IHC surrogates for most of the molecular alterations. We don't have to fear. And let me tell you that it is good if the pathologist learns molecular pathology. Today we are all moving into that era. We may not be able to afford it in our center to perform some molecular tests, but I'll tell you that science will keep on growing, and we are moving into the molecular era, and it's important that each one of you learns molecular pathology along with your histopathology and gross pathology. It is very, very important. So with that, thank you very much, Sumit, for giving me this opportunity. Thank you, Rakesh. Thank you, Kajari. It was wonderful to see Rakesh after so many, I think almost a year or so. Yeah. And thank you all so much.
Even I don't get to see Rakesh. So thanks to you, Vani, he came.